about each of the cases as we go through. Here are my disclosures. I do research that is sponsored from NIH, but also foundations, and I work with several pharmaceutical companies on clinical trials. As well. Next slide. I'll say there's no relevant disclosures to this talk. This is what I'll be talking about today. So if we go back one slide, I'm going to start first with just a little bit of an overview of cerebellar anatomy. We'll talk a little bit about some different forms of cerebellar ataxias, and then end discussing sporadic cerebellar ataxia. I like to start with the anatomy and general approach. I believe in the field of movement disorders, cerebellar ataxias are some of the hardest to diagnose. And especially if you're earlier in your career, you're a medical student, resident, even a fellow, these can be challenging cases in the clinic. And the reason why is because there's so many causes of cerebellar ataxia. Now, I have really focused on the cerebellar ataxias, but I'm not going to talk much today about multiple system atrophy. So many of you have probably experienced multiple system atrophy in the clinics or on the wards. These patients do have a cerebellar ataxia, especially if they have MSA type C. However, just given that I only have an hour with you guys, that is probably the subject of another talk. So go ahead and advance the slides and we'll get started. So let's start first with cerebellar anatomy, and this is just a reminder of what part of the brain we're talking about. So the cerebellum sits in the posterior fossa below the tentorium cerebelli, and you can see in the middle of this slide, the green area, the light green area that's illustrating the cerebellum. Now, this view reminds us that there's direct connection to the pons, and on the far right of this slide, you can see what the anatomy of the cerebellum looks like if we were to map it out in a 3D version. There is a vermis of the cerebellum in the middle, and then there are two hemispheres on either side. There are within the cerebellum 3 lobes. There's a flexular nodular lobe, which is the most primitive part of the cerebellum and connects to the vestibular nuclei. There's the anterior lobe and then the posterior lobe. The posterior lobe is the newest portion of the cerebellum. And why does this matter? Well, it helps us a little bit as we're localizing cerebellar lesions, especially if we have a focal lesion within the cerebellum. I'm not going to be talking a lot about focal lesions within the cerebellum. I'm going to be talking mostly on disorders that affect the cerebellum as a whole, but we just want to review the anatomy so we understand localization. Next slide. There is a very close relationship between the cerebellum and the brainstem, especially the pons. And as we recall from neuroanatomy, the cerebellar peduncles are incredibly important when we talk about localization and pathways of dysfunction. So the cerebellar peduncles are split into 3 different areas. The superior cerebellar peduncle is going to be housing the efferent fibers. The middle cerebellar peduncle, the pontine fibers that are going back and forth from the pons, and then the inferior cerebellar peduncle for the afferent fibers. Now, if we're looking at imaging of the cerebellum, the vermis and the hemispheres, the abnormalities we see are frequently going to be located both in MSA and some of the other genetic ataxias as far as white matter abnormalities in the middle cerebellar peduncle. So that particular area is going to be an important area that we're going to come back to later in this talk. Next slide. So let's just talk about localization. Cerebellar dysfunction, if you have a focal lesion, is going to present with signs on the ipsilateral side of the body compared to where the lesion is located. So if you have a right hemispheric lesion in the cerebellum, you're going to have symptoms on the right side of the body. Now, the vermis is going to supply clinical features to the midline of the body. So the vermis supplies cerebellar function to stance and gait and to the eyes. So if you have an abnormality in the vermal area of the cerebellum, you're going to notice mostly gait cerebellar ataxia, and you're going to have potentially titubation if it's very severe. Titubation is this inability to maintain your stance or maintain your posture, and it will manifest as just some slight movements of the entire body. If you have oculomotor disorders, frequently those will also localize to the vermis. Most of the disorders, again, today we're talking about are involve global Purkinje cell dysfunction. So you won't be able to localize them frequently just by the eyes alone, but it does remind us that the eyes are incredibly important when we're looking at cerebellar disorders. Sometimes you will have a cerebellar disorder that is really distinguished by a unique eye finding. So you want to make sure you do a very good eye motor exam. You look for nystagmus, you look for saccadic pursuits. You may see other abnormalities within the eyes that will help you narrow down your differential. As far as hemispheric dysfunction, these are usually supplying our limbs. And so you will see decomposition of movement in your arms and legs. You may see a decrease of tone if you have severe cerebellar dysfunction. You can see some abnormalities of speech, and you will see tremor. And the cerebellar tremor looks a little bit different, tends to be more variable, more irregular, and is not consistently rhythmic in the way that we might see a Parkinson's tremor or an essential tremor. Now, what you can see in the bottom of this slide, the bottom left, is there is a topography of the cerebellum. And again, we can use this with our localization. But again, many of the cerebellar disorders are not going to localize specifically to one area because of the global dysfunction. On the right, we just want to remind ourselves that the Purkinje cell is the principal neuron of the cerebellum. It has GABAergic output, and the axons of the Purkinje cell do not project outside of the cerebellum. So we're going to be having those projection fibers that go over to the pons that then communicate with the rest of the nervous system. Okay, next slide. So let's talk about a general strategy if you see a patient in your practice who has ataxia. And we're talking specifically about cerebellar ataxia. I'm going to just start with a very simple algorithm that what you can do by taking just a look at the patient, at the age of the patient, and their family history of a strategy of how you're going to think about them as far as diagnosis. So if your patient comes in and they have onset earlier than the age of 25, if they have sporadic disease or if siblings are affected, you're going to be looking at autosomal recessive cerebellar ataxias. If the patient on the far right of this slide comes in, their onset is over the age of 40, you're frequently going to be using your sporadic ataxia algorithm. Not always, but frequently. In the middle, the variable onset patients who have a family history with a parent affected, you're going to start initially thinking about your autosomal dominant cerebellar ataxias. Next slide. So let's start first with the patient who comes in with an onset younger than 25 and you suspect a autosomal recessive cerebellar ataxia. So this algorithm is the most difficult of the algorithms. I'm starting off with it just so that we can make it easier for the rest of the slide deck. Now, there are several papers published that have algorithms that continually add newly discovered autosomal recessive ataxias. But this gives you a general framework. Usually you can use an algorithm like this to give you a strategy in the clinic. So if you're somebody who sees primarily pediatric patients, or if you see patients at all age ranges and you're capturing a lot of cerebellar ataxias, you're going to want to have this at your disposal in the clinic or in your office so that you can use as a reference. So the first branch point, the first step you will always take if you suspect an autosomal recessive cerebellar ataxia is to test the patient for Friedreich's ataxia. And the reason why is because this is the most commonly inherited ataxia, and especially in the US. And, it's definitely something that can be tested for easily with a one gene test. If it's positive, you've completed your workup. If the test is negative, then you're going to look at the brain MRI. I find the brain MRI and cerebellar ataxias to not be as useful as it is for many other disorders we would look at in the nervous system. But if there is cerebellar ataxia, it may help you narrow down your first and second lines of testing. Some of the tests that you are going to do can be run through the general lab. You can look at a peripheral blood smear for some of these disorders, vitamin E levels, alpha-fetoprotein, for ataxia, telangiectasia. You may do immunological studies for some of these disorders. And if you catch something that's abnormal, it will, again, narrow down the list of disorders you're going to be looking for. Almost all the disorders on this slide, actually all of them, are genetic disorders. They're all abbreviated. So for example, AOA is ataxia with oculomotor apraxia. You may be able to get to this genetic disorder just by looking at the neurological exam and seeing the ocular apraxia. But if not, then there are panels that we'll talk about later that you can order that will cover all of these genes for you. So again, you want to have some kind of algorithm at your disposal as a reference. And although we may not be going through all of these, let's go through some slides to illustrate how you would use an algorithm like this. Next slide.
The rainbow is a
So we're going to first start with this video on the left
many
side.
beautiful colors. These take the shape of a long round arch with its path high above and its two ends apparently beyond the horizon. Today is a nice day. Today is a nice day. Me, 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 me. T, 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 T.
So this patient I just saw a month ago, and what you could hear with her speech is that she has a dysarthric speech. You may not be able to hear it until you continue to listen to her talk. And here we're looking at her eye movements, and hopefully you can see she's got a little bit of saccades when she's pursuing.
This one I'll have you do both together.
And here with some of her rapid alternating movements, you see a little bit of clumsiness.
Arms straight out. That would be maybe fudging the exam.
As she's doing her finger to nose, there's a little bit of intention tremor here on the right. And there's, what you can see is some dysmetria when she's getting back to the target. So many of these cerebellar patients will have both tremor and dysmetria. And then unheal the shins. She's kind of missing the shin a bit here. She's got some lateral movements.
And then when you turn around, I'm going to have you.
So sometimes as these patients are walking, they're narrow-based. And so you really want to make sure you have them tandem gait. I usually make them do 10 steps. And what you can see is here, she's unable to do it without holding on to the wall. So there are clearly signs both in her limbs, in her eyes, in her speech, and in her gait of cerebellar ataxia. So we'll go ahead and watch this video on the right. This is a patient who came into the clinic who's a little bit older. She's in her 60s. One more time.
A mischievous spectacle in Czechoslovakia. Safety issues. Remove or rearrange any furniture that may interfere with walking around your house. Keep a clear path. Remove all throw rugs and tack down loose carpets. Always wear good shoes with rubber soles.
And so for her, again, you can hear that her speech is dysarthric. And this is the check, her rebound response. And what you can see is that her arms are moving more than we'd expect for a patient who is normal. And so this is another cerebellar sign you can look for. For her, she's got, again, some difficulty with finger to nose, some dysmetria that we can see.
The next I'm going to have you put your finger right in
A
front of
little bit of attention tremor as she gets close to her nose.
touch it, but you're going to fall.
And now we're going to do the finger chase. So this is on the ataxia rating scale, and it can also illustrate dysmetria. And what you can see is that she's supposed to be right directly following my finger without touching it, and she's having a hard time making it to that target.
This hand up and down.
And with pronation, supination, she's a little bit asymmetric, but both sides appear to have dysmetria, dysdiadochokinesia. And then same thing with heel to shin as our other patient. She's got some lateral movements.
All right, I think so.
Many of these patients actually walk within the hallway just because they can be a little unsteady. And what you can see is she's wide-based. She actually has a little titubation you can see of her trunk as she's moving. And again, it's that the center of gravity, the brain's trying very hard to keep the person in primary position, and they're having difficulty with sway. So what you could see with these two cases is they both have cerebellar signs. And both of these patients have Friedreich's ataxia. I was going to do an ask for what you would do first. But if we look at these patients, the first patient had no family history at all. And the second patient came in with a family history of a sister who was affected with ataxia. So for both of them, even though the second patient was a little bit older, we would be thinking about Friedreich's ataxia. So this is probably the most important ataxia to diagnose right now because there's a new treatment for this disorder. So let's talk about Friedreich's ataxia. So Friedreich's ataxia is caused by silencing of the frataxin gene by an expanded GAA repeat. And you can see a little illustration of this over on the upper right-hand side of the slide. So frataxin is known for being an iron chaperone. It prevents oxidative stress. And so some of the therapies are believed to be helpful because they target these iron pathways. This is the most common hereditary ataxia in the Western world. Onset is usually in childhood or adolescence. However, you want to think about it in the age of, despite the age of your presenting patient. The signs are typically starting with balance and coordination abnormalities. The patient may also have sensory loss, although they might not describe it for you in the clinic. They frequently lose their reflexes. So you want to be thinking anybody who's got what looks like a peripheral problem on top of the nervous system ataxia, you want to be thinking Friedreich's. As you heard in the videos, they have dysarthria, they can have eye movement abnormalities, they usually have normal cognition. So this is a systemic disorder. The silencing of this gene causes problems, especially with the heart. And so these patients develop left ventricular hypertrophy. Almost universally, if you order an EKG in these patients, they're going to have inverted T waves. Many of them do fine for quite some time without cardiac problems, but you want to make sure as soon as you diagnose them that you send them to cardiology to establish care and make sure that there's nothing going on currently. 10 to 20% of these patients develop diabetes, and there's a whole host of other issues like scoliosis or optic atrophy. Now, there's a number of variants. They're called variants of Friedreich's ataxia. The first is late onset Friedreich's ataxia, and that would be the case for our second video that we saw. This patient presented well beyond 20 years. She was in her 60s when she came into the clinic. And then the second type that we talk about is Friedreich's ataxia with retained reflexes. And it's important to remember this because I think when we learned about this disorder in medical school, we learned they always lost their reflexes, but in fact, we now know that there are some patients who retain them. So you still want to be thinking about Friedreich's even if they have reflexes. Next slide. Now, some of the issues in Friedreich's ataxia are still being described in greater detail. And one of the posters that came out this year that I think is really interesting, one of the studies, is looking at what actually is causing some of the problems in the peripheral nervous system. And it's actually coming not from the nerves themselves, but from spinal cord damage in Friedreich's ataxia. So spinal cord damage is a hallmark of the disease, and there appears to be structural damage that occurs. So this is a very nice study done by a large consortium looking at Friedreich's ataxia and imaging. They're looking both at imaging of the cerebellum and imaging of the spinal cord. And what they found is that there's significantly reduced spinal cord area at all levels, and it correlates very well with disease severity. So it looks like there are two things that occur in patients who have a Friedreich's ataxia gene mutation. There is first a developmental abnormality with the dorsal columns, and there's also a degenerative abnormality that occurs as the disease progresses. So we're learning a lot more about the disease and as it affects the spinal cord, and this is leading to some of these abnormalities we're seeing on the exam. Next slide. So the reason why it's so important and why I've started with Friedreich's ataxia is there's a new FDA-approved medication now that it was approved in February of this year, and it's called omaveloxolone. So this particular compound is an activator of NRF2, and it increases the expression of antioxidant genes to maybe counteract some of those problems we talked about in that first slide. So this study was called the MOXIE study. It was a phase 2 for safety and efficacy. And it was a double-blind randomized placebo-controlled trial with 51 patients and 52 controls. They used the modified Friedreich's ataxia rating scale and did a 1-to-1 randomization of omaveloxolone versus placebo. What they found is that the treated patients had more improvement on the scale. Now, remember, this is a motor scale, so it didn't necessarily include outcomes such as the cardiac outcomes or development of diabetes or any of these other signs or symptoms of disease. But clearly it's helping these patients as far as their motor function. And what you can see on the right of the slide is you can see the change in the Friedreich's ataxia rating scale. In the upper line is placebo, it continues to worsen, and in omaveloxolone, it actually remains more stable. And in fact, in some patients, it improved. You can see the same data in the lower graph, but depicted in a different way. Now, there are some side effects with this medication that you need to know about. It does increase liver ALT levels and actually some of the other liver function levels. It does cause headache, nausea, and fatigue, so you need to warn your patients about those. Next slide. So a few more comments about this particular medication. It is estimated to be about $70,000 per year. It is available, so you can write a prescription for this. It is sent through a specialty pharmacy. The patients take 3 capsules of 50 milligrams daily. They take it all at one time. And if the patient is on a CYP inhibitor, you need to adjust it just because it can cause that elevation of liver enzymes. So prior to prescribing this particular medication, you want to make sure you check LFTs before starting. You want to also check a BNP and lipid parameters prior to starting because it can elevate those. And especially if the patient has high cholesterol levels, you're going to want to get that under control before you put them on the medication. This medication is FDA approved for age 16 or older. We do not know how it performs in pregnant individuals or with breastfeeding. So you do need to warn your patient. There is not data. They'll need to come off of it if they conceive or if they're planning doing some family planning. So exciting new development. This is available. You can put in a prescription for it. Next slide. So let's turn next to the autosomal dominant cerebellar ataxias. This is one of the algorithms that I use. And, you know, we are up to 49 SCAs, spinal cerebellar ataxias. So any strategy that you can use to narrow it down is important. Now, when I first started practicing, we were only able to send individual gene tests. So if I saw a patient and I could narrow it down to SCA2, I would send SCA2 only. This is really not the strategy that we currently use. We usually will do a panel to look for the spinocerebellar ataxias. However, if you have a patient who has restricted funds and can't afford to do that, and you're quite confident that you think that you've identified the correct spinocerebellar ataxia, you may be able to send off just that one gene test. And we are successful sometimes in doing that. I look at the patient with ataxia and all their other features and imaging to try to figure out if I can narrow down the ataxia. So if we could go back one more slide. So what you can see on this slide is that if you have a patient who has cerebellar ataxia, but they have, for example, spasticity, you might be thinking about SCA 1, 3, and 7. Those might be at the top of your list. And they are also 3 of the most common SCAs in the United States that we would be thinking about. If the patient has ataxia and has epilepsy, you might be thinking about SCA 10 or 13. And in fact, you might also add DERPLA to that as well. Now, if you have no clues at all in the bottom right-hand side of this slide, the 5 most common spinocerebellar ataxias in the US are 1, 2, 3, 6, and 7. 7 has retinal abnormalities to it. So your SCA7 patients should have visual abnormalities. So if the patient has no problems with their vision, doesn't have any visual complaints, you would be thinking about 1, 2, 3, and 6. And these are going to make up to 80% of the SCA patients that are going to walk into your practice. Just a strategy. We don't usually necessarily send off these individually at this point in time, but if that's the way that you need to do it because of your patient's resources, you would think about 1, 2, 3, and 6 first, and you would use some kind of strategy like this to try to narrow it down. Next slide. Okay, so we're going to look first, we're going to do each video and discuss the video before we go on to the next video. So we'll go ahead and play this first video on the left. Okay.
Mischievous spectacle in Czechoslovakia.
Good. Again, patient has slurred speech. I'm giving you some great examples of slurred speech. They don't always have this. And then what we can see on the pronation supination is that he's got some clumsiness and ataxia. So here we've asked him to stand up and walk. And what you'll notice with him is that he's got this stiffness in his lower extremities. And on exam, it turns out to be spasticity. He's wide-based. He really can't walk by himself. He needs help. But it's this cerebellar ataxia pattern which decomposed changes from the spasticity. Help us with this patient. And this patient does come in with a family history. He had an affected parent. And so on the next slide, I'm going to show you what the strategy we would use to diagnose this patient. So let's go ahead and play the video on the right. And I've got the scans of the patient on the right underneath it.
March, April, May, June, July.
So I think her eye movements may be a little hard to see on the video, but she does have some problems with her pursuits. They are jerky or saccadic as she's moving them. And you can also see in this image her titubation, her head titubation. You'll see it, I believe it, when she walks as well. Now, some of these patients will actually have a head tremor. And in her case, it may be hard to tell, but as you continue to watch her, you can see it's continuous. So in her case, she may have a cerebellar head tremor. We don't see that very often. It can be hard to distinguish from titubation, but it may help you if you can sort out that it looks rhythmic and continuous. On her finger to nose, we're seeing she's got some problems hitting the target accurately. So she's got some dysmetria. And again, some intention tremor as she gets close to her nose or close to the target. Frequently do these tasks we would do in a Parkinson's patient looking for bradykinesia. And then as she's walking, she's got this characteristic wide-based stance that we see in cerebellar ataxia. As we look at her images in the bottom right-hand side of the slide, what you can see is that she has got cerebellar atrophy, and it's global, I should say cerebellar volume loss. And you can see it really includes the vermal area, and so this localizes well with her gait abnormality. Go ahead and advance. I think I have a couple animations on this slide with some additional features. So on this first patient, he had slowed saccades and spasticity, if you go back again. And then on the right video, this patient also has progressive cognitive decline. Videotaped her, and also a son with developmental delay in epilepsy. And this becomes very important when trying to narrow down the differential diagnosis. Let's go ahead and advance to the next slide. So once we advance, we're going to advance one more time for the animation. So the animation here, go ahead and advance once, is for this first video that we just saw. So if we look on this algorithm, this patient had spasticity and slowed saccades. So with the green circles, We can narrow this down a bit. He had no visual abnormalities. So with the green circles, our first patient turned out to have SCA3. So this particular method was very helpful. And at the time, we did not send panel testing. We sent individual gene tests. We sent SCA3. And in fact, it was positive. The patient on the right, she had a head tremor, as we could see. She had a son with epilepsy, and she had dementia. So when we look at those three boxes on here, the one that we are seeing is DRPLA, or dentatorubulopallidoluysian atrophy. So this particular ataxia usually falls off of the SCA papers, but it is an autosomal dominant ataxia. We want to continue to remember it. It is really, we have a lot more of these patients in Asian populations and in Black patients, especially who are from a certain area in the South around the Haw River. So that particular video was from a patient who had moved from that area of the country, but was part of that, her family was from that Haw River area. Next slide. So there are a number of papers, and I thought that this was a nice one reviewing the signs and symptoms of the autosomal dominant ataxias. When the autosomal dominant ataxias were being discovered, they were put into several categories, ACDAs 1, 2, and 3. In the clinic, how helpful is this? Well, it may be helpful in some ways because if the patient is a pure cerebellar ataxia, it's going to narrow down what you're going to be ordering. And if we look at the pure cerebellar ataxias in the US, we're most likely going to be looking at a SCA6, but you can see there's a whole host of other SCAs that will present that way. So these types of papers will help us with strategy. And I think table 1 is the type of table that I use in the practice, trying to narrow down which SCA that we're looking at. Why does it matter? Because some of the panels will have varying types of SCAs, and some of these SCAs actually aren't available on panels. You have to get somebody in a research lab or if you can look for something like dystonia in your patient, that will narrow it down. If you see chorea, that may narrow it down. Again, we see that in DRPLA, ophthalmoplegia, visual impairment. All of these things are going to help you really narrow down your differential. Next slide. So where are we with the SCAs? So this year at the ataxia I described called SCA50, and this was a kind of a collaborative research project with 2 large cohorts that were screened for this new gene mutation. It was initially identified in a French-Canadian family, and they found it was quite likely French Canadians, 18% of German, 15% of Australians, and 10% of patients from India. It was 50-50 man, woman. The gait ataxia was in almost every single patient. Limb ataxia was also very common, and they had the cerebellar signs we would expect. Now, a third of these patients did have vertigo. So if you have a patient with vertigo, you might be thinking about this particular ataxia. The patients, for the most part, had cerebellar volume loss. And the genetics are that this was a novel GAA expansion in the fibroblast growth factor gene. The gene was already implicated in SCA27. So when they went back to look at the actual gene, they decided to rename this SCA27B with the original mutation being SCA27A. So if it weren't complicated enough in the SCAs, we now have A and B at least for SCA27. So we are at the naming system now to SCA50. That means there are 50 of these, remembering that many of the SCAs may only involve one family. We've already talked about the most common ones that you may see, but this may start to move up on our list given how many patients it is affecting. Next slide. There are several studies going on looking at targeted treatments for these various spinocerebellar ataxias. I think this one is a nice one looking at erythropoietin that's been looked at several times in SCA2. It does look like we are seeing improvements in the SCA functional scale with erythropoietin. And what they're trying to do is give it in a way that doesn't, that is easier for patients. So this particular study is looking at a nasal solution. It is not yet available for us to give to patients, and it's very likely we need to see this in a bigger study. This was only 34 patients, but we will be on the lookout for this because it does look like it's helped at least function for these patients. Next slide. Riluzole is a compound I'll come back to in a few slides that has been studied in a series of patients of all different types of ataxia. There's a nice study where they looked at multiple patients and gave them riluzole versus placebo. So this particular study is dialing it down a little bit more specifically into SCA2. And in fact, it does not look like it improves clinical or radiographic outcomes in these patients. So even though the original riluzole study that looked at multiple types of ataxia showed that it can be effective for gait ataxia and other ataxia signs, it may specifically not be helpful for SCA2 or some of the individual ataxias. So hopefully as these studies are completed, it'll give us some idea of who we should be prescribing this to. Next slide. There are several studies coming out now looking at repetitive transcranial magnetic stimulation in the ataxias. This is a nice study done in SCA3 that was prospective and randomized with a sample size of 44 SCA3 patients. The issue is that the stimulation is given over 2 weeks, over 30 minutes, and the device is actually placed over the cerebellum, not over the top of the head that I have in the illustration here. And it does look that it does improve the ataxia motor signs that we see on the rating scales. However, the effect is typically short lasting. So it's not clear how you continue this therapy over time and whether it continues to be effective or whether the effect is lost. So this therapy has been tested across many of the ataxias, looks promising, but we don't know yet how to deliver it and what dose and for how long to maintain benefit. Next slide. So what do you actually do in the clinic now in 2023? And my genetic counselor, Mark Rosenbaum, who I think joined us at this talk today, has given me his real-time what he does as of last week. And so we work very closely with our genetic counselor. We have a full-time genetic counselor here in movement disorders because it changes so frequently. So if you suspect somebody has a trinucleotide repeat expansion, like some of the ones we've seen before, but you really have no idea what it is, you do not start with exome or whole genome sequencing. And the reason why is because you may miss the repeat, especially with exome sequencing. So you want to start instead with a trinucleotide repeat panel for ataxia, especially if you have a coverage for your patient. So the two companies we have been using in the most recent past are Centogene and GeneDx. I do not get any kickback from any of these. This is just our current workflow. So Centogene has a nice comprehensive ataxia panel. It has 483 genes on it. And they do have this compassionate care pricing where you can get this panel for about $500. So this is a much improved number for patients to pay. When I first started my career, the comprehensive ataxia panel had about 30 genes on it and cost about $30,000. So it's come down quite a bit in price. There's a lot more genes on it, but it's still expensive if your patient doesn't have the capacity to pay. Now, GeneDx also has a sequencing panel with 1,000 genes, or a repeat expansion panel that's more limited with 6 genes. So you could consider either of those panels. There are other companies that also have panels. If the panel is run and it's negative, many of the companies will reflex test or go on to exome or whole genome sequencing for you. And if you have the patient use one of these special programs, you can get the cost down to about $500 for exome sequencing or $1,000 with whole genome sequencing. Now, some of these companies will rapidly change their protocols. And so GeneDx just went to an institutional arrangement only. And so you'll have to utilize your genetic counselors or the other folks who get pre-authorization to help you figure out where you can get this test done. And so on the right-hand side of the slide, you can see that actually Blueprint Genetics does also have a financial assistance program. If the patient cash pays, you can get that cost down even more. Next slide. So we're going to talk next about sporadic cerebellar ataxia. This is the last algorithmic approach we're going to use. So for sporadic ataxias, these are patients that don't have a family history that present over the age of 40. You're going to want to use your imaging, and you're going to want to use other things in the history and exam to narrow it down. So for example, if the patient has autonomic involvement, you're going to be thinking about your multiple system atrophy. If the patient has a long history of alcohol abuse, you want to take that into consideration. Again, we're going to be thinking always about Friedreich's ataxia. If there's a rapid course, you want to think about prion disease, paraneoplastic disorders, autoimmune disorders, or Hashimoto's. You usually don't see Hashimoto's with ataxia, but you want to keep it on the list so you're looking for it. If everything here, they don't really fit into any of these boxes, then you can go back to your genetic testing or look for something like vitamin deficiencies or autoimmune disorders. If everything is negative, all your testing is negative, they fall into this sporadic ataxia category. And if they're over the age of 55, at least half of these individuals will turn out to have multiple system atrophy. Next slide. So this case came into our practice from a family that had no family history. And what you can see as the video starts to play is that you can't really even tell he's moving.
2019,
So this particular patient has mass facial expression.
14, 13, 12, 11, 10, 9.
We can't really hear his voice
3, 2, 0.
very well. But what we do hear when we hear it is that his speech is soft. So he actually has kind of a Parkinsonian flavor to him. On his eye movements, we can see there's just maybe a little bit of jerkiness to his eye movements, both in the horizontal and the vertical plane.
August, July.
Yeah. Palms in. Palms up.
We can start to see a little bit of tremor come out with posture.
Thumbs down.
And we see some tremor on finger to nose here. While the video is playing, you could go ahead and advance. I have a couple of other items on this slide for us to look at. As is, he's doing his movements. So here on the right, as we're going to watch him walk.
Get to
Oh
the
yes.
chair, then you can turn around and walk towards
So this patient is narrow-based. And really, when we start to see his problems, they come out on tandem. He has a really hard time with tandem.
All right, and
In a wheelchair, he cannot walk on his own. But it started off with this kind of narrow-based difficulty with tandem gait. And his pull test looks good. This is his tremor that we can see on his video as he's writing, and this is what it looks like. It's really illegible. You can't read his sentence, which says this is a sample of my best handwriting. And if you'll go ahead and advance one more, we'll see his image. Yeah, he will pour the water. Go ahead and advance the slide one more time for us.
that's fine.
And there we see he's got an imaging abnormality. So what we see on this image is he's got a T2 hyperintensity in the middle cerebellar peduncle, and that is very specific for a particular disorder. Go ahead and advance to the next slide, and that disorder and advance. Is located here in the middle. So this disorder is going to fall into our abnormal MRI with a patient with cerebellar ataxia and tremor, and it's an abnormality found with a mutation in the Fragile X gene. So as a reminder, the Fragile X gene sits on the X chromosome, and usually we have 29 or 30 repeats in this gene. Because it's on the X chromosome, men have one X and one Y, women have two X's, so they'll have two Fragile X genes. This disorder is when that repeat, the CGG repeat at the end of the Fragile X gene expands into the 55 to 200 range, you will develop this disorder. Next slide. This disorder is called the Fragile X associated tremor ataxia syndrome, and these are the typical signs and symptoms that we see. It is more frequently seen in men versus women because they only carry one Fragile X gene compared to women who have two. So women who have a second Fragile X gene are somewhat protected from the disorder. It usually occurs over the age of 55. These patients have ataxia, tremor, and cognitive issues with varying amounts of Parkinsonism, nerve problems, impotence, and hearing loss. Next slide. This particular disorder, the reason why we want to make sure we diagnose it is it can impact the rest of the family. Fragile X syndrome occurs when that repeat gets passed down from a premutation carrier and the gene expands. When the gene expands over 200, the whole gene gets turned off and no Fragile X protein is made. So what you can see in this pedigree on the left-hand side of the slide are the black boxes in the last generation. Those are boys with Fragile X syndrome. Fragile X syndrome is the most common inherited cause of intellectual disability in boys. The boys are more severely affected than the girls, and they have this classic phenotype that you can see in the pictures of a prominent forehead, long face, large ears. They have seizures, they have stereotypies. So the reason why it's important to recognize this disorder is that now this FACS-TAZ has been discovered for about 20 years. FACS-TAZ patients are now walking into the neurologist's office and getting diagnosed, when in the past, it used to be that these individuals were identified because of the Fragile X syndrome child. Because that doesn't happen anymore, if you identify an individual with FACS-TAZ, you want to immediately counsel the family, because there's an opportunity for those who are planning to have families and are premutation carriers to consider other options to have children to avoid having an individual with Fragile X syndrome. So they can do pre-implantation genetics or use other strategies in their family planning. Next slide. The last slides I'm going to talk about today, I think we'll probably stop after this last case. This is a case of a patient who came in with ataxia for 6 months and a history of alcohol abuse. And I think it's a really good teaching case for us because he had been seeing...
form a rainbow. The rainbow is a division of white light into many beautiful colors.
All right, look to the right, left, right, left, right, left, down, up, down, up, down. Palms in. Palms up.
So for this patient, he doesn't have really prominent dysarthria.
Thumbs down.
However, you know, he does have a very short time for ataxia.
Palms down.
And it's really, I thought, out of proportion to what we would expect for somebody with chronic alcohol abuse. So this type of case is really important because this would fall in the subacute category of onset. And so you want to identify these patients quickly because they fall into a little bit different differential. I don't know if we could advance to him walking. And so when he walks, he's actually, again, narrow base. And we're really going to start to see the ataxia for this patient as we hand him. Or as we stress
With me again. You can get closer to the wall if you feel comfortable, just, yeah.
You can see he's got houses handy.
Try not to. Turn around and sit way towards the chair.
Go ahead.
All right, that's good. First pull. Second.
So this is just a reminder that many of our patients who walk in with subacute ataxia can have paraneoplastic disorders. And the reason why it's so important is because you may be the first person to identify cancer in this patient. So we have had patients walk into our practice. They had a paraneoplastic ataxia. We may or may not have found the antibody, but when we looked, we found a cancer and we were able to send them on to oncology. Sometimes you can pick them up at very early stages and you can save the patient from having a later stage cancer and demise. So there are many antibodies that cause paraneoplastic ataxia. This is not uncommon for us to see if you're seeing a lot of ataxia. New antibodies are discovered all the time. Go ahead and advance to the next slide. And you know, some of these individuals will improve. Now, if you remove the tumor, some of them may go back to normal. I have seen that in our practice. Usually, removal of the tumor will cause stabilization if you catch them early enough. The evidence for immunotherapy is not great, but we do use several things in these patients. We'll use corticosteroids, IVIG, plasma exchange, sometimes rituximab. If you combine therapies, that may stabilize disease as well. So the strategy on the right in summary is to find the tumor and take it out, and then consider immunotherapy. If you can't find the tumor, you may go ahead and treat presumptively, but remember that only 50 to 60% of these patients have identifiable antibodies in the CSF or serum. So we are at time right now. I don't see any questions in the chat. Maybe we'll end with this last slide on medications for ataxia. What you can see here is there are some medications that have been published that can be helpful for the symptoms of ataxia. Riluzole has the highest level of evidence, so you might want to think about that one. You want to monitor the LFTs in these patients. We use a lot of amantadine because it's cheap, it's easily available, and can help. I usually have to go up to 400 milligrams in these patients. Sometimes we'll think about buspirone or varenicline, but again, they have mixed evidence. I think I will end there. If there's any questions in the chat, I'm happy to answer them, but thank you for coming. And I'm happy to answer any questions by email too, if you have those. Thank you.
Dr. Hall, there is one question in the chat.
Okay, so the question in the chat is, do you test for Friedreich's ataxia even if other systemic symptoms are not present? It depends a little bit on the patient. So if the patient comes in at any age and they don't have reflexes and there isn't a good explanation for that, yes, we test for Friedreich's ataxia. And we're actually testing more and more for Friedreich's now that there's a medication available that may slow down the disease. So I think your threshold for Friedreich's should be very low. If the patient comes in and you can check off the boxes for multiple system atrophy, they're older, they have autonomic dysfunction, they have retained reflexes, you may not test that person for Friedreich's. But if they're younger and they have ataxia with nothing else that would be unusual for Friedreich's, test them for Friedreich's first. Friedreich's, male, female, ethnic predisposition, it can affect everyone. So I would, again, low threshold for testing. You can send off a single Friedreich's ataxia gene test. We just did it last month for that first patient we showed. So you might consider doing that. It's going to be less expensive for your patient. I think that's it. Thank you for having me.
Thank you, Dr. Hall. That was a very comprehensive review. It's been a pleasure.
Great. Thank you.